Am I audible now? Yes. Am I audible, boys and girls? Yes, yes. 1 minute, 1 minute. I'm just checking the audibility. Am I audible now? Huh. Yes. So, yes, boys and girls, I think I'm audible. Everything is perfect. Now, let's get started with the session. Okay. So, let's get started. As I told you, we're going to come with the recall sessions of physiology. And we'll be trying to cover as much as possible theory with this. Right? Audibility. Am I audible now? Yes. Yes, yes, yes. Now, the first question which had been there was a figure which was given to you, right? There was a kind of a figure which was given to you, and the question was asked that which of the transport process, right, which of the transport process across the cell membrane is it showing? And the options were simple diffusion, facilitated diffusion, done, primary active transport, or whether it was secondary active transport. And this was the figure which was given to us, right? Now, what is important over here is, see, you can see that you are getting something, that there is a molecule which is getting transported, and this is a carrier protein, but this carrier protein is just showing a conformational change. That means there is no use of ATP, right? The first important thing is that there is no use of ATP, but there is a use of a carrier protein. So what did we find? We found that there is a conformational change. You can just look over to the structure of the carrier protein once the molecule that is to be transported, and just a change in the conformation, but there is no use of ATP. So there is something where you are using a carrier protein but no ATP. So let's look on to the options. When there is simple diffusion, so what occurs with simple diffusion? Definitely with simple diffusion, we know that we don't require ATP, and not even ATP. Very, very important thing is that there is no use of any carrier protein, right? So it is not only ATP but no carrier protein. As far as your primary and your secondary coactive transport mechanisms are involved, right? Your primary and your secondary coactive transport mechanisms are involved, you will see that they use a carrier protein, right? But they are also going to use ATP. So there will be a carrier protein and there will be an ATP. So that is going to be our primary or a secondary coactive transport mechanism. This figure is definitely what is facilitated diffusion. Very, very important MCQ, and one of the very confusing one. Why confusing is, in the case of facilitated diffusion, you are using a carrier protein, but you don't use an ATP. It is just by a conformational change in the carrier protein. This is subjected to what we called as competitive inhibition, right? It is subjected to what we called as competitive inhibition. This property is very important. The same thing you study in pharmacology also. It shows stereo specificity. What do you mean by stereo specificity? This means that if suppose there is a carrier protein to which L-glucose can attach, okay, there is a carrier protein to which L-glucose can attach, the D-dimer cannot attach, right? The D-dimer cannot attach. That is what is called as stereo specificity. Another very, very important is it shows saturation kinetics. It shows saturation kinetics, and what we express in the form of TM, that is transport maximum. So this is something very, very important with our difference between your active transports and facilitated. The facilitated will bear the same features like the facilitated diffusion, but ATP will be used only with active and not with facilitated diffusion. Now this can also come, suppose I want to have a graph related to this. I can give you this question in the form of a graph. So if I give you a graph and I draw one as a linear correlation and the second one I draw a plateau. On the x-axis there is going to be the solute concentration, on the y-axis there is going to be the rate of transport, right? Rate of transport. So isme you should see that whenever there is a linear correlation, it is going to be your simple diffusion. And remember that the simple diffusion is only and only with your lipid soluble substances. It is only with the lipid soluble substances. So it could be your gases, it could be steroids, and this property is very, very important. I'll just give you another question related to you so you'll become very much clarified. Now whenever you get a plateau, right, whenever you get a plateau, this plateau signifies saturation of carrier proteins. So there is going to be saturation of your carrier proteins and therefore you get a plateau. Now this you also get in kidney. Kidney mein you study this for the transport of glucose. And one important thing what we draw over here in the kidney is this phenomenon which is called as splay, right? So what is the cause of that splay if I just want to add on? So the cause of that splay, which is especially when we speak of kidney and the reabsorption of glucose which shows transport maximum, this splay is because of the nephron diversity. What is nephron diversity? I mean to say that there is a difference in the reabsorptive capacities of different nephrons. Kidney is having about 1 to 1.2 million nephron each kidney. So every kidney has got its own saturation and therefore the facilitated diffusion ka jo graph hai. So this is the graph of facilitated diffusion. But if I want to make a splay, I just put it a bit rounded. So that shows a nephron ka diversity. That means a variation in the reabsorptive capacity, and that is why there is going to be a difference in the value of the renal threshold, that is 200 milligrams per deciliter, between the TM, that is 375 milligrams per minute in males and 300 milligram per minute in females. So this nephron diversity results in a difference that when there is renal threshold, you don't get your saturation kinetics. Why we don't get is because of the nephron diversity, and that what gives us to what we called as our splay, which we are getting in this. Okay. Now, again, one important difference which we would take between our we will be taking one important difference between our simple diffusion and facilitated diffusion, right? So one important difference which you should know between your simple diffusion and your facilitated diffusion. We know that both of them are not using energy, right? One important thing, that facilitated diffusion is faster as compared to simple diffusion. You may also get another MCQ. For example, I may give you different hormones. For example, ADH, T3, insulin. Okay, I may give you ADH. I may give you ADH, T3. I may give you insulin, or I can give you suppose oxytocin. And I may ask you that which of the following hormone shows simple diffusion. Again, the hormone that shows simple diffusion will become T3, because this T3 is lipid soluble. So remember that this question with general physiology is very, very important, right? So facilitated diffusion ke baad mein just have a look over this active transport, that is your sodium potassium pump. Okay, the active transport, that is our sodium potassium pump. Now, the sodium potassium pump itself is a very, very important image based question, right? You can see that it has got alpha and beta subunits. So this is the beta subunit, which is smaller, and this is the alpha subunit, which is the active or which is the regulatory unit. Okay, so it is the active or the regulatory unit is your beta subunit, is your alpha subunit. This beta is meant only for glycosylation, right? It is only for glycosylation, but it is the alpha unit which is active. Now you can see that this is the site which is intracellular. Why sodium is intracellular? Because you have to pump sodium outside, right? You have to pump sodium outside. So intracellularly you will be having sites for sodium, phosphorylation sites and ATP binding sites, right? You will be having sites for phosphorylation and you will be having the ATP binding sites. Whereas on the ECF you will be having the sites for potassium, because potassium has to be taken inside. Very importantly, you will be having a site for digitalis, that is your coabin. So here is going to be the site which is going to bind your digitalis, that is coabin, that is a cardiac glycoside, because you know that the cardiac glycosides, they have got a positive inotropic effect, right? They have got a positive inotropic effect. That means they increase the force of the contraction. So one of the important mechanism is that they bring about inhibition of this sodium potassium pump, right? They bring about inhibition of the sodium potassium pump, and by way of this they are interrupting the function of the sodium calcium exchanger. So calcium remains inside, creating a positive inotropic effect or a increase in the force of contraction, right? So this question, which is related to our active passive transports, is really important one from your general physiology. Now this is typically an example of our secondary co-active transport, wherein two molecules are coming inside in the same direction, right? For example, sodium amino acid, sodium glucose or sodium bicarbonate. So two molecules are coming inside. Now why the secondary is secondary? So this is the sodium potassium pump on the basolateral side, and this is going to be coupled with another transporter. Suppose that transporter is SGLT, right? That transporter is our SGLT. Now because why this is called primary? This is a primary active and this is my secondary active. The primary is going to be present on the basolateral side or the interstitial side, and the secondary is always present on the luminal side. Why this is primary? This is primary because it is breaking down or bringing about the primary hydrolysis of ATP and driving the sodium out with a coupling ratio of 3 sodium outside to potassium inside, with a net loss of 1 positive ion. So it is causing the sodium concentration to be less inside and also taking the positive charge. That means it is creating what? It is creating electrical gradient and it is creating concentration gradient. Both the gradients are created. These gradients are so much sufficient that they can allow the sodium to be dragged inside. So the sodium is going to move along the concentration gradient. But remember, sodium alone, if it binds, this co-transport molecule will not work. So this will also allow any other, which could be amino acid, which could be glucose, to be taken inside. So two substances are coming in, wherein the sodium is along the concentration gradient and the amino acid or the glucose are against the concentration gradient. And obviously यहाँ पर on the basolateral side you're going to get a facilitated diffusion. There's going to be the glues which will take, or there could be amino acid transporters. So primary is causing or creating a gradient which is establishing energy in the form of this gradient for the secondary coactive transport. And therefore one of the important MCQ which you get, that in the ORS, why do you add glucose? So it is not only for taste. When you add glucose to ORS, what happens is that this glucose, it is going to enhance the reabsorption of sodium. Sodium is osmotically active, it will drag water, and whenever sodium is reabsorbed, there is going to be reabsorption of chloride, right? So just in one slide, if I have to sum up the entire transport mechanisms, so if I have to just give you one slide and you tell me, ma'am, please summarize the various transport mechanisms, so you can summarize them as active and passive. Active is your primary. Please remember that primary is not only the sodium potassium pump, but the calcium ATPase pump, that is the SERCA, and even the hydrogen ATPase pump, which is present in the lysosomes, which is present in the parietal cells of stomach, and also present in the eye, that is the intercalated cells of kidney, will become primary. Secondary will be your various co-transports and your counter transports, and passive is diffusions. These diffusions can be simple, it can be facilitated, or it can also be non-ionic diffusion. And apart from diffusion, the other important part is osmosis, right? So this is in brief or in nutshell, if you want to just conclude the session on active transport. And the last point before I just shift on to the next MCQ. Remember that the sodium bicarbonate reabsorption is coupled with sodium hydrogen exchanger. So at one point there is a co-transport, at another point there is an antipode. This is especially in the PCT as well as in the small intestinal cells, right? So this is all with the MCQ. Let's move on next. Now second, there was a clearance graph being given to you. So this was the clearance graph, right? And you were given 3 graphs and they were marked as X, Y and Z, right? X, Y and Z. And now you have to tell me what is the correct one. What is X, Y and Z? Looking into the options, you can see that X is glucose bicarbonate inulin, or it is inulin bicarbonate glucose, or it is glucose bicarbonate PAH, or it is inulin PAH or your glucose, right? So anybody would like to give me the correct answer with this? This is what we called as the clearance curves, right? This is the clearance curves. So the correct answer is D. What is it? That X is inulin, Y is paraminohippuric acid and Z is glucose. So let's look into the clearance curve. Now this is my inulin. So on x-axis we have taken the plasma level and on the y-axis we've taken clearance. Why this is inulin? This is inulin because, why it is inulin? It is inulin because inulin is a substance which is neither only filtered, so neither it is reabsorbed and nor it is secreted. So because it is neither reabsorbed nor it is secreted, it is something which is only filtered and you're getting a straight line, right? If you look into the curve of your glucose, what is happening to the curve of glucose? So it is rising. That means initially when the plasma glucose was up till 200, right? When the plasma glucose was up till 200, you could see that the clearance of glucose is almost zero. That means no amount of glucose is being excreted in urine. But as the plasma level of glucose rises, you will see that the appearance of glucose increases. That means if the concentration or if the plasma concentration of glucose rises, right, if the plasma concentration or the plasma glucose rises and it crosses its threshold, the clearance of glucose will increase, right? The clearance of glucose will increase. That means the amount of glucose will now be more in the urine. There will be positive urine glucose. Now if you compare with that of your PAH, remember PAH is a substance which is secreted but it is using a carrier protein. As the plasma concentration of PAH increases, we see that the clearance decreases. Very interesting. So substance which is reabsorbed, uska clearance बढ़ रहा है, right? The substance which is reabsorbed, the clearance of that substance is increasing, but the substance which is secreted, the clearance of the substance that is secreted is decreasing and its plasma concentration will rise. Now something very interesting, even if the that the plasma PAH clearance is decreasing and the clearance of the glucose is increasing, you will see that they become parallel to inulin, right? They become parallel to inulin, but they never become same to inulin. That means the lines are never going to merge, right? So if you these three, what I want to say you, that this is your inulin, right? And this will be your glucose which will be parallel, and this will be your para-aminohippuric acid which will be parallel. So they are trying to come close to inulin, right? They'll be trying to come close to inulin. They will be parallel to inulin, but they will never be same as inulin. That means this line is never going to touch or this line is never going to touch. What is the reason? The reason is very physiological. Inulin is a substance which is only filtered, neither secreted nor reabsorbed. If you consider glucose, kitna bhi glucose ho, whatever level of glucose rises in the blood, some amount of glucose will always be reabsorbed. So its clearance will keep on increasing, but it can never become same as inulin. Similarly, para-aminohippuric acid, even if you keep on increasing its concentration, small amount of para-aminohippuric acid will always be secreted. So it is never going to be a substance which is purely filtered like inulin. So the two clearance curves are very, very important MCQs, and it is totally opposite. Clearance of the reabsorbed substance will be increased and the clearance of the substance that secretes will go on decreasing. A similar type of question was there couple of years before in your NEET PG, wherein the question said that if the PAH infusion was done and the PAH level was by mistake given more by the technician, so this is going to result in a false low value, right? It is going to result in the false low value. Now on the contrary to this, you have got another figure. Here on the x-axis is the total length of the proximal tubule. So what we've done is on the x-axis we've taken the total length of the proximal tubule in percentage, and on the y-axis we've taken the TF to plasma concentration. What is TF? It is the tubular fluid to plasma concentrations, and you get a variety of curves over here. So you can see that some of the curves, you can see that some of the curves are above 0, 1.0 or 1, and some of them are below 0 or below your baseline of osmolarity. So some of them are more than 1, some of them are less than 1, and a very favorite question is the tubular fluid to the plasma concentration. Now whenever you have to study this, you must first understand the logic. What is the logic? you will have to understand that you have to compare the reabsorption of solute and solvent. Solvent will be, that is, water. So you will have to compare that what is reabsorbed more. So यहाँ what you are doing is, towards the end of the proximal tubular length, you are basically examining what is relatively reabsorbed more, whether it is the solutes which are reabsorbed or whether it is the fluid which is reabsorbed. For example, let us consider sodium. So if I ask you what is the tubular fluid to the sodium for the tubular fluid to the plasma ratio for sodium, or you can say it regarding to the osmolality, right? So what is the tubular fluid to the plasma ratio, whether it is more than 1, it is less than 1, or it is equal to 1, right? Now you can see that the sodium and water are almost equally reabsorbed. So it is not there that the sodium reabsorption is more or the water reabsorption is more. It is almost same. That means towards the end of the proximal tubule, the concentration of sodium and the concentration of the water, or the water amount and the sodium, will be same, and therefore the osmolarity of the tubular fluid to the plasma will be equal to 1, right? But if you consider substances which are secreted like urea, like creatinine, towards the end of the tubular fluid, the ratio or the amount of creatinine which will be left in the tubular fluid of the PCT will be more than water. It will be more than water. This means the water reabsorption is slightly more than that of water reabsorption is more than that of the solutes. So what will happen? The solute concentrations will be more, and therefore the tubular fluid to the plasma ratio will be more than 1 for the substances which are secreted, right? The tubular fluid to the plasma concentration will be more than 1 for the substance which are secreted. But if you consider glucose, water reabsorption is 60 to 70% in the PCT, but the reabsorption of glucose is 100%. That means when we move towards the end of the PCT, there is zero glucose but there is water. Excuse me. Therefore, the tubular fluid, right? Therefore, the tubular fluid to the ratio of the tubular fluid to the plasma ratio of glucose will be less than 1. So to make it very simple, all those who are having a value more than 1, these are the substances which are staying behind as compared to water. Those substances which are having the ratio less than 1 are reabsorbed more than water. Now, very interesting, let's consider inulin. What is the tubular fluid to the plasma ratio for inulin? Right, the TF to P ratio for inulin, more than 1, less than 1, or it is equal. So this is really interesting, that what is going to be there when you consider inulin. Now again, what is the concept? The concept is that you have to compare the reabsorption of water and the reabsorption of inulin and along the length of PCT. Right, along the length of PCT. So when you consider towards the end of the PCT, both of them are filtered, but we know that water is reabsorbed. Water is reabsorbed, but inulin will be left behind, right? This inulin will be left behind. So when you are moving towards the end of PCT, you will find that the concentration of inulin is more than water, right? The concentration of inulin is more than water, and therefore the tubular fluid to the plasma ratio of inulin is more than 1. So don't get confused that inulin is not reabsorbed, not secreted, it is only filtered. But here we are just comparing the reabsorptions of water, that is the solvent, with a particular solute in discussion. Okay, I hope I'm clear up till this. I am clear, yes, and are you understanding? So yes, is the things very clear, and are you getting up till this? So we move on to the next MCQ, that is related with potassium and with your general physiology again, but then potassium is again very important. Now the question was that there is a 35-year-old patient, right? There is a 35-year-old patient who is with intravascular hemolysis, and the serum potassium is 5.5. What will happen to the RMP of this patient, right? So iske liye it is very important that you should know the normal concentration of, or the normal serum plasma, right? Now it will be more positive, it will be more negative, it will be zero, or it will be unchanged. So anybody would like to come up with the answer, right? Yes, Mithu and everyone, I think you should come up with your answers. Okay, so the correct answer is more positive. So now we'll understand this concept, that is a very important concept, is the effect of potassium on your RMP. Now remember, the normal potassium concentration is 4 to 5 milliequivalents per liter. Therefore the answer, which is 5.5, means the potassium is more. That means this is hyperkalemia. So what is the effect of RMP to hyperkalemia, right? Now before that, certain very basic concepts regarding potassium. Potassium is the only most diffusible ion at rest. Most diffusible ion at rest, because the leaky channels, okay, the leaky channels, they show permeability more to potassium than to any other ion. The reason is, if you look into the molecular weight of sodium, it is less, the radius is less than that of potassium, but the hydrated ion of potassium, right, the hydrated potassium molecule का जो size है, it is much less than that of sodium, and therefore the leaky channels are maximally permeable to potassium. So it is the Nernst potential of potassium that is closest to RMP. That means potassium is the main contributor to your RMP, and there is no role of sodium in RMP. This is very important, that there is no role of sodium in RMP. Now this is my ECF and this is my ICF, and definitely I've got lots of leaky channels over here. So there are lots of leaky channels for potassium. Now what we've done, we've increased the potassium concentration. There is hyperkalemia, okay, there is hyperkalemia, and I increase the potassium concentration outside. Movement of the potassium, right, movement of the potassium is always through this leaky channels. It will be either because of an electrical gradient, or it will be either because of an concentration gradient. So if the potassium is more outside, so please remember, please listen very carefully. If the potassium is more outside, the potassium which is inside, will not go outside, because there is no concentration gradient. Already there is lots of potassium in the ECF. So जो potassium ICF में है, it will not go outside. That means inside will be more positive. So you will have a more positive RMP, right? If there is more positive RMP. Yes, Tom, I will. Yes. Just we'll explain that also. Right? There will be more positive RMP, and once the RMP is more, it can easily cross the threshold. Once it crosses the threshold, the excitability of that membrane or that tissue will be more, right? So if already the ECF concentration में the potassium is more, the potassium which is in the in the ICF, the potassium which is inside will not move outside, right? So more positive ions inside and they're not going to go outside. More positive RMP and excitability. Opposite will be the case if suppose there is a decrease in potassium outside. So you are bringing about hypokalemia. So what will happen? All the potassium which is inside will move outside to maintain this concentration gradient, right? In this case, this RMP will become more negative, that is hyperpolarization, and the excitability will decrease. So potassium per se is a very important MCQ for RMP and also with kidney, right? Now, one case history, suppose if I give you that there is a 16-year-old boy who is a sprinter, and he complains that as soon he is exercising or he does his sports, he develops lots of muscle weakness, excess of muscle weakness, especially after exercise. So this time he being taken to the physician immediately did a serum potassium level and he found that there was a decrease in the potassium level after exercise. Now again, this is what is diagnosed as our hypokalemic periodic paralysis. So what is happening? That there is a decrease in the potassium level. As the potassium level in the ICF decreases, the potassium which is in the as the potassium level in the ECF decreases, as the potassium level in the ECF decreases, the potassium which is inside in the ICF will move outside, creating more negative RMP, and that is going to result in hyperpolarization. That hyperpolarization results in weakness, because if it is more negative, right, if it is more negative, that means more amount of the inward current is required to bring about the upstroke of action potential. If you don't bring about the upstroke of action potential, you cannot bring about contraction and the person will be having muscle weakness. Now in this case, the doctor advises to avoid carbs. Why did he avoid carbs? This is typically an autosomal dominant channelopathy. It is an autosomal dominant channelopathy, and the doctor advises to avoid as far as possible the exercises and also avoid carbs. What is the reason? The moment you take carbs, there is going to be an insulin spike. Insulin stimulates the sodium potassium pump and it increases the uptake of potassium into the cells, and this is going to exaggerate the hypokalemic periodic paralysis, right? Now this is a very interesting table. The concentrations which are going to affect the ECF potassium and the potassium concentration. So it is going to be reduced with insulin, with aldosterone, with beta stimulation and with alkalosis, whereas the potassium concentration increases with insulin deficiency, aldosterone, beta blockers, acidosis, cell lysis and exercise. What is the very important effect of acidosis? Suppose if there is acidosis, there is an increase in the hydrogen ions. These hydrogen ions will be taken inside so that they are buffered by the proteins, right? They will be taken inside, so they are buffered by the proteins. So once this hydrogen ions are taken inside, to maintain electrical neutrality, potassium will be thrown outside, and this is the reason that why acidosis results in hyperkalemia, right? Now as Tom, you have asked me the question related to calcium and sodium. let me tell you that sodium is only going to affect the magnitude of action potential, only the magnitude. So if you are getting an increase in the size of this upstroke, right, if you are getting an increase in the size of this upstroke, this means that the sodium is there, which is more. Sodium has got no role in RMP. There is a very important effect with hypocalcemia, that hypocalcemia causes an increase in the excitability of the membrane. It causes an instability. The reason is, see, such a paradox that calcium is required for muscle contraction, but at the same time hypocalcemia causes spasms. What is the reason? Calcium normally guards the voltage gated sodium channels, right? It guards the voltage gated sodium channels. That means it allows the sodium channels to open only at a particular voltage. But when there is a hypocalcemia, even a small change in the membrane potential will be suffice to open sodium channels. तो जैसे ही sodium channels खुल जाएंगे, small amount of sodium will come inside. Depolarizations, however, they won't be very efficient action potentials, but those depolarizations, spontaneous depolarizations, are sufficient to cause the muscle spasm. I hope Tom Cruise, you've written your name as Tom Cruise, you understood what I wanted to tell you and what was your doubt related sodium, potassium and calcium. Now the next question. The dorsal column was hit from lateral side. Which fibers will be affected first? Options were cervical, sacral, lumbar or thoracic. Right. Okay. Thank you too. So the correct one is cervical. So you can see over here that this is the dorsal column. The dorsal column is your fasciculus gracilis and your fasciculus cuneatus. If you see the arrangement, more laterally is the cervical. Then thoracic, lumbar, sacral. And the question which was asked was that you are giving a lateral hit. So when you are giving a lateral hit, the fibers which were first affected is going to be cervical. So I tell you one thing, that whenever you are remembering, that whenever you are learning your tracks, just learn them in the way we used to learn our maps when we were in school. That means just draw a spinal cord, right? And once you draw a spinal cord, try to locate the tracts. What is present dorsally, what is anteriorly, what is ventrally, because once you locate them and you repeat the same process again and again, you do a rehearsal of it, you will be very much thorough, that where the tracts are located, and then very easily you can solve image based questions, because I can just mark this, and if suppose there is a lesion, which sensation is lost. So it is dorsal column, so all your tactile sensations will be lost. Another important thing, please study the crossing and the difference in the relay station of your anterolateral column and your fasciculus gracilis and cuneatus, which becomes the basic of the Brown-Sequard syndromes, or what is the hemisections of spinal cord. So now I cannot complete it, but definitely I'll try to cover it some other time. Next one. I think this was not very difficult. There's history of a 65-year-old patient in the medicine OPD with resting tremor, with rigidity, with loss of facial expressions, and which part of the brain was involved. So this is definitely not at all a difficult question, a very straightforward question, and options may the correct one is our basal ganglia. Right, our basal ganglia. Now, what important points to be remembered with our basal ganglia, or with the questions given to us? Remember, if it is basal ganglia, there should be resting tremor. which you also called as the pill rolling movement. Facial expressions are typically mask-like face. What is the reason of mask-like face? You know that the portion of basal ganglia, right? The portion of the basal ganglia comes in the part of limbic system, right? The portion of basal ganglia comes as a part of limbic system, and therefore mask-like face is an important feature with basal ganglia. Rigidity is going to be there because it is contributing to regulation of muscle tone, stretch reflex, right? Therefore exaggerated upper motor neuron type of symptoms if there is lesion with basal ganglia. On the other hand, intention tremors, they go more with cerebellum. Other features of cerebellum: nystagmus, a rebound phenomenon, right? A rebound phenomenon. You also get a pendular knee jerk, There is dysdiadokinesia, there is dysmetria, there is typically a loss of the synergism between the agonist and antagonist muscles. So cerebellum. Apart from that, fine tremors are in the patient with anxiety, they are in the patient with hyperthyroidism, right? So around, you also can study flapping tremors. Now if you just come on to this, if you consider the other options, for example, what is going to occur with lesion of the hippocampus? So if there is a lesion to hippocampus plays a very, very important role in memory and learning. So the patient has got difficulty in learning, and what he will develop will be anterograde amnesia, right? Anterograde amnesia. Remember that it shows a very important phenomenon, that is long-term potentiation. Long-term potentiation helps in consolidation, that is converting your short-term memory into long-term memory, right? Short-term memory into long-term memory. As far as the other option which was given was our amygdala. The next option which was given was amygdala. Right. So what is this amygdala? Remember, amygdala is the window of limbic system. It is the window of limbic system. That means through which the limbic system comes to know about the world. The emotions which are generated is only after the inputs which are given by the amygdala. Moreover, this amygdala is very, very important in discriminative appetite, right? Discriminative appetite. And if there is a bilateral lesion to amygdala, you develop psychic blindness. What is this psychic blindness? There is indifference to the quality and to the type of food, right? And indifference to the quality and to the type of food. Psychic blindness with food is concerned. So amygdala is very important part of the limbic system, and it is related to emotions. Now, there was a figure which was given, coming to our next question, which was related to the action potential. So if I take this action potential, right, and the question says that what is the correct sequence? So suppose I just mark over here as A. Let us take this RMP as A. 1 minute. So this is A, this is B to C, and this is my D, and this is my E. So what is the correct option or what is the correct answer? So point A threshold, point B to C is the opening of the sodium channels, right? Point D is the closure of the potassium channels, and point E is the absolute refractory period. So if you look over here, this is your RMP, right? This is the point of stimulus which is given, and from this segment over here, that is this upstroke, is going to be a point where there is going to be the opening of the voltage gated sodium channels, right? Opening of the voltage gated sodium channels. Once you come to this plus 35 millivolts, there is closure of the sodium channels. Remember that the sodium channels are fast to open and fast to close. This is very interesting thing, that they are fast to open and very fast to close. Plus 35, they will close. E, that is going to result in the repolarization. That repolarization is because of opening of the potassium channels, which are slow to open and slow to close. This segment is our hyperpolarization. The hyperpolarization is because of the continued slow efflux of sodium of potassium ions. Okay, there is a continued slow efflux of the potassium ions, and which is resulting in the continued efflux, and the RMP is becoming more negative, which is hyperpolarization. Now, important point to be understood is that if you do not allow, right, if you do not allow the sodium channels to close, so instead of plus 35, what potential can they reach? Remember, they can reach up till plus 65 millivolts. Why plus 65? Because this is the Nernst potential for sodium. So up till this point, what will happen? Sodium will come inside. If you are not allowing this to close at plus 35, it can go maximum up to plus 65. Now at this point, the RMP will become equal to that of sodium, and there will be no further influx of the sodium ions, right? There will be no further influx of the sodium ions. So remember that every ion, it wants to reach RMP, but the ion which succeeds in reaching RMP is potassium, because it is most diffusible at rest. So if you do not allow the sodium channels to get closed, they will keep on allowing the sodium inside, they will keep on increasing the upstroke, or they will not allow the downstroke. What potential? Up till plus 65, wherein the Nernst potential of sodium will be attained. Now, there was a spirometric recording being shown, and what was asked was, I think, this was asked. I'm not sure about it, but I think this was asked. What is this? So the options are your FRC, ERV, total lung capacity, or inspiratory reserve volume. Now, whenever I take my classes, I always tell you that this is a very important section, which comes as image based question. It can come as a clinical based question. It can also come as for calculations. So this is a very important part where physiology is integrated with respiratory medicine. I have taken, I think separately also I have taken a lecture on the lung volume and capacities. Please go into that, right? So you can see that these are all static lung volume and capacities. They are not dynamic. So volume taken in and out, this much is my tidal volume, right? This much is my tidal volume. Now from the tidal volume, if I allow the person to inspire maximally, that will become IRV. So IRV will be at the end of inspiration, but IRV when combined with tidal volume will become inspiratory capacity, right? Now you are going to ask the person to take a deep inspiration and forceful expiration. Vital capacity. Vital capacity is determinant of the strength of the respiratory muscles. This is your expiratory reserve volume, and the volume that remains behind after the forceful expiration is our residual volume. When you sum up the expiratory reserve volume with your residual volume, you get FRC, that is your functional residual capacity. As far as your FRC is concerned, this FRC is very important. It is that volume which maintains or which balances the elastic recoil of the lungs with the chest wall, right? It maintains or balances the elastic recoil of the lungs with the chest wall, and therefore it is also called as your relaxation volume. FRC cannot be estimated by simple spirometer, so you can do a nitrogen washout method, helium dilution method, or a body plethysmography, right? Now, next one, in the case of the infant respiratory distress syndrome, there is deficiency of which of the following lipids? Lecithin, sphingomyelin, phosphatidylserine, or phosphatidylethanolamine. Now you know that your surfactant, this is what we are speaking of, the infant respiratory distress syndrome is actually related to our surfactant, right? So surfactant is a mixture of proteins and lipids. The major lipid is dipalmityl phosphatidylcholine, which is also lecithin. Okay, so dipalmityl phosphatidylcholine, which is also lecithin, right? Now you know that when the infant is a baby, when it is a fetus, it is not taking its own breath, depending totally upon the mother, and you do the sphingomyelin to you do a lecithin to a sphingomyelin ratio, right? This ratio is a very, very important determinant for the maturity of lungs. This surfactant is secreted by the type 2 alveolar epithelial cells, which are also called as the granular cells. This is a very important structure. This is called as the lamellar bodies, and it is these lamellar bodies which are going to form this layer of phospholipid, because they form what is called as our tubular myelin, right? So if you look into the functions of surfactant, very important function is to decrease the surface tension. So this surface tension, if decreased, will increase compliance, and this will therefore decrease the work of breathing, right? It will decrease the work of breathing. This surfactant, the surfactant production is increased by glucocorticoids, also increased by the thyroid hormones, which basically target your lamellar bodies. It is inhibited by insulin, and therefore the diabetic mothers are prone to have babies with respiratory distress syndrome. What is the cause? The cause is that the diabetic mothers have hyperglycemia, especially if it is uncontrolled, which will cross the placenta, which will reach the fetus and increase its blood glucose level. This blood glucose level of the baby will rise its insulin, and this insulin inhibits our surfactant, right? So this is with our surfactant. Remember, when we speak of alveolar stability, the alveolar stability is brought about by two factors. One is surfactant, and the other is the phenomenon of interdependence of the alveoli. They've got a common wall, So if the small is stretched, it will also, so if the small alveoli, suppose this is a small alveoli which is collapsing, this is a bigger alveoli, it inflates. As it stretches out, it is also going to open up the smaller one. So this prevents the smaller one to collapse into bigger one. Out of these two, surfactant is more important in alveolar stability, right? The other function of the surfactant, what is the other function of surfactant? It keeps the alveoli dry. It keeps the alveoli dry. So the alveoli is kept dry by your surfactant and by the negative interstitial fluid pressure, which is also maintained negative by the role of lymphatics. Out of these two, more important is this one. So alveoli dry by both, but more important is by the negative interstitial fluid pressure and lymphatics. Alveolar stability more by the surfactant. Now, the next question given was that you were given the phase of ventricular action potential, and you were asked the ionic basis of that. You know that this is phase 0, 1, 2, 3 and 4, right? So what is the correct answer? Yes, definitely the correct answer is A, that is the calcium channels for the plateau phase. So this is the ventricular action potential. The ventricular action potential, which is called as the fast response, the conduction velocity is more, characterized by a stable resting membrane potential, depolarization as can be seen with the sodium conductance, initial rapid repolarization by the transient potassium efflux, plateau which is balanced by the calcium and potassium, where the calcium conductance is more than potassium, a final repolarization by the potassium conductance, and RMP which is contributed by the sodium potassium pump and by the sodium calcium exchanger. So why did I call this as a stable RMP? Because this is an unstable RMP, that is the pacemaker potential of the SA node, which is called as a diastolic depolarization or an unstable phase 4. This is responsible. The faster this diastolic depolarization, more will be the heart rate. This SA node potential is called as a slow response, having only two phases, 0, 3. Depolarization, repolarization, phase 1 and 2 are absent. That means no plateau and no initial repolarization, and the depolarization is not because of sodium but because of the calcium influx, right? So a very important table, different types of channels which you can see in the cardiac muscles. Fast sodium channels, phase 0. Slow sodium channels contributing to the phase 4 of the pacemaker potential, the funny channels. L type of calcium channels for the plateau, long lasting calcium current. T type transient potassium channels contributing to the pacemaker potential. Potassium channels, transient, that is contributing to the phase 1 initial repolarization. Delayed rectifier for the final repolarization. Apart from this, you've got ATP sensitive potassium channels that respond to hypoxia. You've got acetylcholine activated, that is activated by acetylcholine, by adenosine. They are GI protein coupled, responsible for slowing down the heart rate on vagal stimulation. And finally calcium activated, which are activated by high cytosolic calcium that accelerates repolarization. So boys and girls, I might have missed any of the questions. If there is any question which is missed, it's my opportunity to learn from you. So you can provide me if there are any questions. Remember to let me know if anything else is to be taught to you, to be taken to you. So we at Unacademy are coming up with a rank predictor. So please take advantage of this rank predictor where you can enroll. We are coming with very important thing, that is we are coming up with the preparations of next, right? So our batches have already started, and the next batch is going to start from 28th March. You can use the code REAP9 to avail further financial benefits. So this is all for today from your mentor. More than a faculty, I consider more as a mentor. Please come up with your doubts. I've got a Telegram group, Synapse, for success in physiology. Synapse with the teacher so that we can learn more, right? So thank you all. Take care. Loads of blessings and have a happy learning. Stress-free and a happy learning. Thank you. Best wishes for your results. Do share your results with us. Bye-bye.